Morning everybody. So the idea of taking this topic for you today was that when we were making the schedule, the uterus we have covered in many aspects, including its pathology, and it has been discussed, as you saw now, many things we have discussed. We are going to discuss about cervix. In prolapse, we are going to discuss about the vagina. And two poor organs were getting missed. And those two poor organs are ovary and the tubes. So whatever you do, if you take ovarian mass as a topic, then the poor tube remains. Okay, so I thought I will mix these topics, and together these two things are known as adnexal mass. Okay, I will tell you why these two things we club together in a while. But I hope you know that for femininity, for a lady, not just the uterus is important for her femininity and reproductive function, but important are the tubes and ovaries also. Because ovary is the place which produces two things. What are the two things ovary produces? Hormones and eggs. Okay? And tube is very important. If tube is not there to carry out that ovum inside the uterus, then the lady is going to suffer with infertility for no reason. Because when road was not open there, she is going to have infertility. And that, where she will land up? Where will she land up if she does not have the tube? For IVF, for test tube babies, there is no other option. Okay? So it is a small structure, but very, very important as far as the reproductive functioning of a lady is concerned. So I am trying to couple both the things together. It is going to give you an overview. And the idea of overview is that if any examiner asks suddenly one question, you should not think that, oh my God, I have never heard this term before. So I am trying to take up all those small little terms, whatever we use in this lecture, which I plan to finish in next 30 minutes. So the learning objectives, at the end of this thing, I just want you to be clear about 6 things. First, what is an adnexal mass? What are the types of adnexal mass? What is the clinical presentation? Diagnosis, how to differentiate a benign mass from a malignant mass, and what is the treatment ultimately, because that's what we are supposed to do. Now I told you why these two structures are together. In the midline is uterus, cervix and vagina. On the sides, like 2 ears, are the ovaries and the tubes. On both sides, so the meaning of adjunct is adjoining. Adjoining means next to the main reproductive organ, that is the uterus, these structures are found. That's why they are called adnexal structures or adjunct structures. And why, if you are wondering why we are clubbing them together, there are more than similarities in these two structures which you can think of. Anatomically, how many of you have seen an open abdomen in OT or in a YouTube? Anybody has seen an open real ovary and tube relationship of real ovary and tube? So I suggest all of you should go to OT. We have such good facility. There is a screen outside. You can sit there and see. If you do not utilize this, it's ovary and tube are very close anatomically. They are actually hugging each other in the anatomical position. They are together. Because they are together, so disease of one, suppose there is infection in one organ that tends to spread in the other organ also, and they tend to form a conglomerate, one mass, which we call as adnexal mass, and if you look at it, you will not be able to say where is the tube and where is the ovary. So they stick to each other and make a mass. Third point is, they are like best friends. Okay, so this best friend business is very good also, very bad also. If you are best friends, if anybody does anything, A person does anything, Sita does anything, Geeta gets blamed for that. And because of friendship, you cannot tell also that she did or I did. So whatever these things are happening, they run as couples or in friends. So exactly, if you remember these best friend concept, you will remember that why they behave similarly. They have similar pathological behavior. When we are doing ultrasound, it is very differentiated. Whether Sita did it or Geeta did it, because they are all the time together. saying that actually the ovarian cancer, which were treating for ages, for centuries as ovarian cancer, that actually starts in the fallopian tube. Still, we are not clear whether the cancer starts from the fallopian tube or it starts from the ovary. So they have similar kind of debated malignant origin. And the best thing for students, undergraduate, nobody is going to ask you about the staging of fallopian cancer because we have some set questions which we ask our. But PGs, if you get by chance a question on fallopian tube cancer, you don't have to think anything. Everything, staging, management, everything is exactly like ovarian tumor. So that makes the job easy also. So these two structures are so close together. Now, types of adnexal mass can be inflammatory. So this slide is to give you an overall view of what all can happen in this adnexa. There can be an inflammatory mass. There can be some masses which are specific to pregnancy. There can be some masses which are just functional. There can be non-neoplastic masses, and then neoplastic masses which can further be divided into benign mass and malignant mass. Now, when we say about inflammatory mass, inflammatory means infection. And what is the infection of the pelvis, pelvic organs, genital tract called? PID. We are going to study in another lecture about that. So PID. And with infection, actually nothing can stay in the tube inside because it is open from both the ends. But by chance, because of this inflammation, adhesions occur in both the ends, it gets filled with, first how it will get filled with pus, because macrophages are very fast and they are trying to attack the bacteria. So first it is filled with turbid fluid, which is pus. Then this macrophages start dying off. Then the infection starts settling down. This fluid which is pooled inside doesn't go away in totality. Why? Because the tube is blocked from both its ends. So this is how hydrosalpinx and pyosalpinx are formed. In infection, I told you whatever comes here goes here and there. So if there is infection, there is no infection. All are hematogenous infection or ascending infection. So whatever comes to tube or ovary, it tends to involve the other structure also. And together they stick together and make a mass that is called TO mass. And when it is very in the infected state, it is known as TO abscess. So these are the inflammatory mass, hydrosalpinx, pyosalpinx, TO mass and TO abscess. Pregnancy related. Now, a few years ago, there was a sessional exam I was invigilating, and there was a question that one patient has something pregnant lady, and she had molar pregnancy of 8 weeks, and she had 15 centimeter cyst on both sides. How you will manage? Can anybody answer? This is pregnancy related cyst, which is because of high level of beta STG. What is the cyst called? Theca lutein cyst. It can be 10 centimeter, it can be 100 centimeter. You are not supposed to touch it. Once the pregnancy goes away, slowly the cyst also will go away. Okay? And you will not trust me, not 99.9%, 100% students got really alarmed to see the size of the ovaries. They said that we will do bilateral ovariotomy or bilateral cystectomy. That is a wrong answer. So this message, examiners will try to trick you in exam that what you are going to do will be cyst. So pregnancy related to ovarian cyst, if it is corpus luteum, theca lutein cyst in pregnancy, or even corpus luteum cyst, you are not supposed to touch those cysts. The other cysts which can happen during normal menstruation cycle only are called, how is the cycle of ovarian cycle is divided into 2 halves. First is what happens in the first part of the cycle, pre-ovulatory folliculogenesis. After that, follicle releases one egg and whatever is remaining becomes what? What it becomes? Corpus luteum. And after 14 days, corpus luteum dies. Now imagine a situation when a follicle is growing. Follicle means lot of fluid and one shown to egg there. That egg has to come out from a small hole. By chance, there is some problem, some little disturbance here and there in the body, and that hole that punctum is not created, then what will happen? This follicle will keep on growing in size and it will become a cyst. It is not abnormal. It is just that one minute opening has not happened in the follicle. This cyst is known as follicular cyst. Now in corpus luteum shrinks. This follicle, when all the fluid comes out, it becomes corpus luteum. Now suppose that pinprick-like of punctum which was there, it gets clogged. It is very small nanometric punctum. So if it gets clogged by some blood or mucous material, then fluid will keep on collecting inside that. Okay? Then what kind of cyst it will become? Corpus luteum cyst. So these all are. So why I am telling you this, that if by chance you get a short note on corpus luteum cyst, you should write how it happens, whether it is normal or normal, how do you diagnose, I'll tell you, and what is the ultimate treatment is, just wait and watch. So all these things which I have written here, if you get a question, my idea is you should be able to tell the examiner something or write at least one paragraph correctly about that, not gossip, correctly. Okay. The third kind of cyst is non-neoplastic. The name is chocolate cyst. Okay, but trust me, if you do one case of chocolate cyst in OT, for 1 month at least you will not eat chocolates. Okay, it is a dirty fluid, dirty concentrated blood and debris. I don't think it looks like molten chocolate from any way. It doesn't look like, it is a dirty fluid, but maybe somebody was in very good mood. They named it chocolate fluid, okay? Don't say, I'm going to see when chocolate cyst surgery. It is not that beautiful surgery. But chocolate cyst, you know, what is the other name of chocolate cyst in ovary? Endometrioma. Or endometriosis inside the ovary is called chocolate cyst or endometrioma. Then benign cyst, there can be a group of, if you start reading the classification of neoplasia of ovarian tumors, it is huge. It's very difficult to and very boring to understand. So you must know only few things. It can be cystadenoma. Adenoma means benign. It can be fibroma or it can be a dermoid cyst. The malignant counterparts can be either epithelial tumor, germ tumor, sex cord stromal tumor. Well, little bit, I am not going into details of any of these, but I just want to know that these are your topics and probable questions which may be asked to you as short notes or and they might also somewhere. So, clinical presentation. As you can understand, clinical presentation varies depending on what kind of adnexal mass it is. But some important things I wanted to tell you. First is the age. So here age is no bar. And adnexal mass can occur in a teenage girl also. You cannot, like postmenopausal bleeding, you will see that some things you cannot say when you are presenting a case of postmenopausal because they happen only during reproductive age. For adnexal mass, there is no rule. Age is no bar. A 15-year-old, 18-year-old girl can also present with an adnexal mass, and even a postmenopausal party can also present with an adnexal mass. But age, it can happen in any age. That does not mean that we will not ask the age of the patient. Age helps us to differentiate. Suppose it is happening in the reproductive age group. Like ma'am was trying to give you a hint here. So some things, endometriosis happens only in the reproductive age when the lady is operating. Fibroid, we are not talking of fibroid right now, but say endometriosis, PID, these are the things which happen only during reproductive age group. In extremes of ages, you have to think of malignancy. So germ cells tumor occur in early age group when the child is small, comes with an adnexal mass, and late stage, if an old party comes with an adnexal mass, what is the first thing that should come to your mind? Which cancer, which ovarian cancer out of what I told you? 80% of the patients in postmenopausal age group, if they are having an ovarian cancer, you know the diagnosis. It is what kind of ovarian cancer? Epithelial ovarian cancer. Remember this, okay? It is epithelial ovarian cancer. So age, it can happen in any age, but if you know the age, it really helps to differentiate in your case diagnosis. Parity. Now have been trying. Can you name few adnexal masses out of the list I gave you, which will be seen in infertility or nulliparous patients? Which one? Chocolate cyst. Very good. Very commonly associated with subfertility or infertility. Next, hydrocephalus, pyosephalus. These all things can occur in. So parity also has a role to play. Now, very important thing. The problem with adnexal masses, they do not have a specific symptom. Symptoms are very vague. There is no, one thing I wanted to, the last line, usually these masses, most of the times, except for like endometriosis or chocolate cyst, most of them are not associated with any menstrual abnormality. So for undergraduates, what I teach, in the middle of the night also, if somebody wakes you up and tells you which menstrual abnormality you will have in ovarian cyst. So ovarian tumors or ovarian cysts usually do not present with menstrual abnormalities. Some tumors might present or some cysts might present with benign abdominal distension, abdominal pain, but hardly any menstrual disturbances and malignancy. The problem with ovarian malignancy, especially if it is a epithelial type what we were talking about, it mimics which problem? Which problem? It mimics gastritis. Patient will have just the feeling of nausea, vomiting, early satiety, post-meal distension, that's it. And my first case of missed ovarian malignancy I saw when I was in first year. I don't know, ma'am, I don't know whether you were there or not. Actually, patient was missed. And when we operated, it was already stage 4 ovarian cancer. So they present, this is very important understanding. If a patient, if a lady keeps on coming with symptoms of gastritis, and you do her ultrasound, there is an ovarian cyst, take it seriously. It can be an ovarian cancer. So, signs, what signs you will present? When you are writing your thing in exam, so it is very important that history and examination should corroborate. Whatever you are saying in history should be seen in your examination. Okay? So, if there is something which is causing menorrhagia or malignancy, these women will complain of, these women will present with pallor. And whenever there is pallor, even if because of this thing, anxiety, if you are not able to palpate patient pulse, please increase it, say that tachycardia. We are not going, when we are sitting as examiner, our idea is not to ram you, but see in times of crisis how your mind is working. On the day of exam also, you are not missing important things in the patient. So if there is pallor, what will be the pulse rate? Bradycardia, normal, tachycardia. Tachycardia, okay? So you should know that and you should implement. That's how we judge a student who is better than other students. Then weight. Tell me in ovarian malignancy especially, weight will be less or weight will be more. There will be a history of patient will say, I have gained weight or I have reduced. Actually, patient may be losing her tissues because of malignancy, but because of huge ascites. Okay, now this question is for PG. So what specific question? I have told you, we discussed it before. So what you will ask, weight gain and weight loss will be a problem if you ask. You have to ask the lady if her garments which she wears, blouses are getting loose and lower pants are getting tight. So because she has abdominal distension, but actually she is losing. Later she will explain what that is. Okay. Now abdominal, I think pelvic examination and abdominal examination, all that you have covered. How will you feel the mass, and that has been covered. But I want to emphasize one point here. Every adnexal mass is not palpable per abdominally. For any pelvic mass to be palpable per abdominally, it should be more than 12-week size. All are with me in this? Okay. If it is 8-week size, so every mass need not be palpable. Usually hydrocephalus, TO masses, all these things will not be palpable per abdominally, but still you cannot, every mass, only if you can palpate it abdominally, is not necessarily an important factor or that we have to make a diagnosis. There can be some mass which are more than the normal size, but still in the pelvis. Now, how do you make the diagnosis? After taking these three, doing per abdominal, per vaginal examination, if you are thinking that most likely it looks like an adnexal mass. So, first question is to confirm it, whether it is actually adnexal mass or not. The second question is that what kind of, I have given you a list of things which can happen. What kind of adnexal mass it is? By mistake, the answer is written there. So, what is the investigation of choice? Say it loudly. Ultrasound. How do you decide whether you want to do an abdominal ultrasound versus a vaginal ultrasound? So, simple, you keep when you are examining, if you can feel the mass in the abdominal examination, per abdominally, you first start with abdominal examination. If you cannot feel it, but you think that there is something wrong in the pelvis, you do a pelvic scan or vaginal scan. Is it clear? Okay. So now what, this answer was written here, but what I am showing you now, I'll show you three pictures. It is difficult to diagnose what particular kind of lesion is there in the adnexa, but this thing which we really use helps, and exam also you will remember it. Okay? So masses can be of three types: good, bad, and ugly. Okay? Good. What do I mean by good mass? Good mass is a clear cyst. First one is the clear cyst. One cyst is there and there is no separation, there is no debris in between. Second mass is also not, it's not very good but not very ugly also, because it is homogeneous in consistency. Okay, not very clear, not looking like an egg or a follicle. It is little dirty, but at least it is homogeneous. If you compare with the third mass, okay, it is totally irregular in shape, full of separation, something in between, not looking nice. Anybody feels that ugly mass is nice? Okay, so you are with me. So how do we differentiate in ultrasound? First view of ultrasound, we see whether it is good, bad or ugly. Okay, ugly masses are malignancies. Good masses are? Good masses are normal follicular cyst or some kind of that, normal cyst which do not require any treatment. Good people, so you behave like good students, we will treat you nicely, okay? So, it does not require, first thing does not require anything. Second thing actually is endometriosis. So, that is something in between. It can be a benign lesion or it can be some other lesions. The other way is, this is the first step we teach our students. Second thing what we teach is pattern recognition. After seeing so many ultrasound around the world, people have recognized some specific patterns which help us to find out, okay, this can be endometriosis, this can be dermal, this can be hydrocephalus. So important ones I am presenting to you, I am showing you, so that if your viva is really going on well, you can show off to your examiner that I know even more than this. Okay? So the first mass, this appearance is called ground glass appearance. Like you have grounded the glass and put it there. This is typical of endometriosis. What is this called? Say it with me. Ground glass appearance. Second is dermoid. All of you know dermoid cyst. You have seen specimen also. There will be hair, there will be some tooth, there will be bone, so many things will be there. So in this three things rather are important. What is that focal node-like structure, which can be a tooth or can be a something solid which is there. That fluid has white lines, we call them coarse stippling, coarse lines. Why it is? Because it is not filled with clear fluid. It's filled with what material? Dermoid cyst is filled with fat-like material which is called sebaceous material or sebum. So sebum is not clear fluid with some particles inside. That is the fluid. And one is the acoustic shadow. It is important for PGs. Maybe I don't want to tell you that. Third is corpus luteum cyst. How will you describe this? Cobweb appearance. Okay? All of you are having in your room cobwebs. Today you look at them and see how they look. Okay? It is not exactly the meaning of that, but crisscross pattern we call them cobweb appearance. So cobweb appearance, because of organized blood in that, it is said, or this luteal cyst is called cobweb appearance. Can you see that last one? What is the characteristic? It is an oblong swelling with one incomplete septum. Ovarian cyst always, if they are separate, they will have a complete septa in that. If there is incomplete septa from the tube from one side, tube cannot have a complete septum. Otherwise, pregnancy cannot occur. So when this tube swells up, the septa is only on one side. So oblong swelling, oblong clear swelling, cystic mass with incomplete septum is diagnostic. This can be one of your MCQ also. Okay? Is diagnostic of hydrocephalus. Now first time. Case 1, I have taught you enough. 60-year-old party. So they call Dadi's party now here. Richa ma'am. Dadi means party. Okay? 60-year-old party. Para 5, living 5. Presence with abdominal distension, early satiety for 3 months. There is an abdominal mass arising from the adnexal which is up to the umbilicus. Ascites is present, and in ultrasound, this is a 20 centimeter adnexal mass. Ascites is there, which is ugly in 65 years with this container. So it is ovarian carcinoma. Is it difficult? No. If you get this kind of lady in exam, you can answer all your questions. Okay, very good. Para 2, living 2, abdominal distension 1 year. Abdominal mass up to umbilicus again, but ascites is absent, and on ultrasound there is a large clear ovarian cyst. Diagnosis? Very good, benign ovarian cyst. Why do you say so? Age. That's what I think ma'am was trying to tell in her case. You have to start making that patient was in reproductive age group, 43 years. Okay, she is 35, reproductive age group, young patient. She is not on extremes of any age, okay? And there is no ascites, that means it is not a malignant lesion, and it is large, clear, good-looking cyst, so it has to be benign. Is it clear? 23 years old lady, nulliparous. So everything is important in history. 23 years, parity. She is nulliparous, trying to conceive for 5 years, presence with dysmenorrhea, menorrhagia 1 year, abdominal pain for 1 month, there is no mass palpable per abdomen. Okay? What it can be? Ultrasound we have not done. It can be hydrocephalus, it can be tube mass, or it can even be endometriotic cyst. But you have confusion, but when we did ultrasound, there is an oblong cystic mass with incomplete separation. What is the diagnosis, boys? Very good. Okay? I am happy you have understood. Next case, maybe the last case, 31-year-old lady, again nulliparous, anxious to conceive, presence with severe dysmenorrhea for 4 years, 16 weeks mass palpable abdominally, and it is an immobile fixed mass. I'll give you extra points from ma'am's case. It is immobile fixed case, big 16 weeks mass, which is palpable abdominally, nulliparous, dysmenorrhea. Diagnosis? Endometriosis. You are experts. We can finish this one program. You are learning everything. Okay, so this is the same ultrasound shows 10 into 10 centimeter cyst with round glass appearance. Now, the next important question is, how do you differentiate a benign lesion from a malignant ovarian lesion? Okay. Why it is important? Because it can come as the first question. As soon as you take your question paper, first university question can be to differentiate these. You can get a patient as benign ovarian tumor or a malignant tumor. You can, when we ask you specimen, we'll ask you, we'll show you a cyst and we'll tell you to differentiate benign versus malignant. So one of the maybe 10% of the questions will be around this in your exam. So you have to understand properly. And when anybody asks you about benign compared to malignant ovarian tumor, don't start, that is true for any case, don't start describing from the tumor. We are looking the patient as a whole. So your diagnosis starts with age of the patient. Okay? So age is benign lesions will be in reproductive age groups. Malignant lesions will be as every time they will be in old lady, but here in Adnexal it is a little different. They can be in teenage girls also. If she comes with an ovarian cyst, it can be a malignant ovarian tumor. That is the difference. So extremes of age will present as malignancy. There is no menstrual complaint except for few. You can remember, you can take the endometriosis. Endometriosis also there is a little more game to it, which we are not going to discuss today. But symptoms usually are not menstrual symptoms. Benign will present with pain and distension. Malignant, non-specific symptoms. Okay, early satiety, post-meal distension, like gastritis kind of symptoms, you will not be able to find out what it is. When you do abdominal examination, very important question, size does not matter. A malignant lesion can be this big, and mucinous cystadenoma might be occupying the entire abdomen. So don't say big size means big problem. It's not like that. Sometimes small people are enough to trigger bigger problems. Okay? So size does not matter here. So, but the mass will be cystic and will be nicely mobile. In malignant, there will be ascites. Most of the times, or many of the times, the tumor will be involving both the ovaries. The consistency, somebody said last time, variegated. Do you understand what is the meaning of variegated? Variegated means ovary usually cystic, but if some solid areas are there, the consistency varies from one point to another point. Variety is called variegated. Somewhere it is looking cystic, somewhere it is not. Very well. Or by chance, by mistake, if you say CA125 in exam. Okay? So one of the very important discussion is how CA125 helps in diagnosing. It does not help in diagnosis. We do not make any diagnosis based on CA125 or any other tumor marker for that matter for adnexal masses. So importance are only two. It helps in prognosticating the disease and for follow-up. So if CA125, what is the normal CA125? Normal CA125 boys? 35. Okay? If it is 100, it is okay. If it is 10,000, that means prognosis is bad. Disease has already spread. Okay? So prognostication is the meaning when we are seeing the patient how bad and how much the disease is spread. The other is follow-up. Once you have removed the tumor, after that 6 months when patient comes, her CA125 should keep on dropping. If 3 years later she shows a sudden rise, that means something metastasis is happening or something is going on wrong. Tumor markers for undergraduates. I have another theory for postgraduates. For undergraduates, tumor markers are not important for any benign adnexal pathology. Treatment. If it is functional cyst, what is the treatment? Shout it loud. Wait and watch. No treatment at all. If it is not malignant, even if it is not malignant, even if hydrocephalus is there, it requires some kind of surgery, but usually it is a simple surgery. It can be removal of entire ovary, removal of tube and ovary together, which is called adnexectomy, or just enucleation of the cyst, which is called cystectomy. It can be done laparoscopically, it can be done by laparotomy, means opening the abdomen. And if it is a malignant disease, it requires a bigger surgery. We have to do complete surgery. I'm not going into details, but 2 terms that you want to read up in your books, these are staging laparotomy or interval debulking surgery. Both mean that we have to remove so many things, not just the ovary. We have to remove the tube, we have to remove the uterus, we have to remove lymph nodes, we have to remove involved part of momentum, we have to remove involved part of bladder column. It is a big surgery. Okay? So what I am going to tell you before I say bye-bye, I will show you one small video. The idea of this video is to make you interested in OBG. I cannot show you all surgery, what kind of surgeries we do. So you see, I want as many people to take OBG, good people to take OBG, because we need them.
It is a 28-year-old non-gravid female with a 7 centimeter simply left ovarian cyst. She presented with intermittent pelvic pain, dyspareunia, and pelvic pressure. A pelvic ultrasound showed a simple cyst arising from her left ovary. A laparoscopic ovarian cystectomy was planned. This fertility-preserving, minimally invasive procedure is ideal for premenopausal women with a low suspicion of malignancy. An incision is made on the antimesenteric side of the ovary, away from the major ovarian blood supply. Care should also be taken to avoid a tubal fimbria. The incision is extended lengthwise to accommodate dissection of the cyst. Traction and countertraction are used to separate the cyst from the surrounding ovarian tissue and enucleate the cyst. The cyst is removed from the patient's abdomen in a contained fashion.
Okay, so this is one of the surgeries, but we do various kinds of surgeries for adnexal mass. It can be laparoscopically, open, many kinds of surgeries. But I'll just summarize the thing which I want. The idea of showing you video was not for the sake of completion, to make you interested in OBG and surgeries. So adnexal mass basically is a Pandora's box. You don't know what is seen here, what ultimately it will come out. It can be a plethora of things which I have already listed in the first slide. Important thing I want you to understand that adnexal mass can occur at any age. There is no age bar for that. Functional cysts are never palpable abdominally. They are usually diagnosed by ultrasound and they do not require any treatment. Treatment is based on entire patient profile. We never treat ultrasound. So you have to see, because if we are doing cystectomy or we are removing the entire ovary, that will depend on patient's choice whether she wants to become pregnant in future or what is the status of her other ovary, what is her age. So treatment is based on entire patient profile. USG is the first investigation of choice. This question suddenly examiner will ask, and I think it is answer for every question in gynecology. If the examiner asks what is the investigation of choice, and if you don't know the answer is ultrasound. The most important is to differentiate between a benign ovarian tumor from a malignant ovarian tumor, because thinking that so many things can be benign, you should not miss one malignancy also. It is okay to operate, do extra for one patient rather than leaving one patient with malignancy and sending home saying that you are okay, it is a benign patient. Okay. Treatment, usually we do not have medical treatment even if it is PID. And sequelae of PID, hydrosalpinx or pyrosalpinx, usually there is no medical management for there. If that mass is causing some problem, some pressure symptoms, some pain for the patient, we have to ultimately go for a surgery. And I think that's it. Thank you so much.
Adnexal mass in a small time period. The topic is so huge, but I really congratulate you. Always care, in your vision.
Thank you so much.